All right, good morning, and thank you for having me back here today. Well, Monday morning, it's a great time to talk about memory loss. That's excellent. So we will start with, now of course this topic, I wish it was a laughing matter. Obviously this is not. This is a very difficult topic because we've seen dementia in those who are older, and if it affects someone in their 50s or even 40s, the suffering is magnified. And I've spoken to this group about our quest to find new treatments for Alzheimer's and dementia, and goodness gracious, it has been extremely difficult to find new medicines for Alzheimer's and dementia. You may remember a talk I gave about trying to move forward with these trials, and since I spoke to you last, more trials have failed. There have been even more failure in Alzheimer's disease therapeutic development. I'm very sorry to bring that news. Of course, the research continues, and we are still searching for these needed treatments for Alzheimer's and dementia, but we're not there yet. And certainly when young individuals are affected, the need is even greater. No competing interests today. We'll talk about early onset dementia and what that term means, and its features and making the diagnosis. And we will talk about the genetics because that plays an important role in the early onset form. And the treatment, what we have today and the enduring hope for the future. All right, so early onset dementia, we must talk about terminology to start with, and this is a very important point, is that many people who use the word early onset dementia will mean that they have early symptoms. So my family member has been diagnosed with early onset dementia, meaning it just started recently and the symptoms are mild. But that is not exactly what early onset dementia means. In fact, early onset is young onset. It's the age, actually. It's not that it started recently and that the symptoms are mild. That's not early onset. It's that the onset was at a young age. And so you'll find that confusion all over the place. And of course today we'll be talking early onset dementia means young onset dementia. So the term young onset dementia is a better term. Now how young? Of course, so that's debatable, but really under 65, yes, but maybe even under 60 really. So the 50s and 40s, this can happen even in one's 40s, and I have had patients in their 40s. But more commonly, it's been in one's 50s. And in that situation, we have a young onset dementia, of course, that has to be diagnosed and treated and find out if there's any genetic underpinning which could be causing such a young onset. Now, if someone is younger, we have some special considerations, and Kelly talked about work at the CDN trying to assist these individuals and their families, because if you are younger, then you're likely still working. Many of our retirees with dementia and Alzheimer's have retired, but if someone is very much actively working, for example, I've had a physician develop dementia in their 50s, seeing patients. So that obviously is a safety concern. I had a school bus driver in their 50s develop dementia, and that brings both the working and the driving issue together all in one as a school bus driver. So special safety concerns in someone younger. They may not be as financially secure. So for example, if they're working, will they go on short-term disability? Will they go on long-term disability benefits? Do they have a medical retirement set up or a pension? And this last one's important, is that I've had patients who were at risk of being terminated due to cognitive errors at work, which were not yet diagnosed. And if they were terminated, then they might have forfeited their benefits due to a medical condition which was not yet diagnosed. So clearly, this is a situation we want to avoid by making the diagnosis and allowing that diagnosis to return to the employer so that benefits can be engaged as opposed to termination. So that is a very real threat that faces some of my patients, and sometimes even legal opinions are required to prevent the employer from terminating someone and removing their benefits, which are now needed more than ever. And lastly, I have certainly experienced this where someone in their 50s, in fact, that physician who I saw in his 50s, had a daughter who was just 10 years old. And so the daughter just kept asking, what's wrong with daddy's brain? Why? And you can see that it creates a tragedy upon a tragedy, even more, having a young family like that. And so this is my general pie chart of the dementia types in the world. And yes, Alzheimer's disease is the most common. Vascular dementia, dementia with Lewy bodies, and frontotemporal dementia. And when we speak of the younger onset, so in one's 50s, it can be Alzheimer's, and we're going to touch on Alzheimer's today, but really the one to focus on is that one, the FTD, frontotemporal dementia. So we'll talk about that, because that one can definitely present in one's 50s, commonly so, commonly. Even when it's not a genetic type. It can just naturally arise in one's 50s. And we will talk about Alzheimer's as well, because there are young onset Alzheimer's type dementias, often of genetic origin. All right, so let's talk about FTD and how to recognize it in often younger individuals. We use the diagnostic criteria from 1998, which still hold up. They have been updated, but they still hold up. So you may have heard of the frontal variant or behavioral variant of frontotemporal dementia. This is the classic type where there's a major behavioral change, and that one becomes very disinhibited, almost childlike. A return to childhood as the brain goes from an adult state backwards to a child state, as usually the frontal lobes of the brain are progressively destroyed. And we'll talk about the progressive aphasias, which you may have heard of, also grouped under the FTD types, and we'll talk about those, the non-fluent and fluent type progressive aphasias, and a rarer type of prosopagnosia, which we'll describe. And so the first type, again, in a younger individual, say 57 years old, over 2 years, gradually develops a major personality change. Now, one might think, oh, that must be a psychiatric presentation. It must be depression, maybe a sleep disorder. It can't be this. But, and as you can imagine, many individuals developing that are seen by a psychiatrist. But no clear diagnosis can be made, and the decline continues in the area of personality. So, someone who was usually very reserved, over 2 years, now starts to become like a child, unable to control their impulses, grabbing everything, eating too many sweets, inappropriate in public, just like my children. And this, of course, is a 57-year-old who was very calm and collected, showing good judgment, maybe a physician or fully developed member of society, now returning to childhood before our very eyes. No insight. They have no insight into their difficulties, emotions which may be flat or inappropriate, decreased personal care, and again, disinhibition, that personality release, that could be FTD, and in such a young person. And the frontal lobes of the brain, you can see on the MRI here, are being annihilated. The brain cells are being killed, and the brain is becoming smaller in the front of the brain, and that is why this is happening. This is not a psychiatric condition. This is highly organic neurological, because the brain cells in the front are being destroyed. They cannot govern or act as the executive to the rest of the brain. Next, in a 58-year-old, over 2 years, gradually developing the inability to speak. You see, we take all of these cognitive aspects for granted, don't we? Until we lose them. Then we realize how precious our executive thought and our language is. And over 2 years, the ability to speak becomes erased. It starts with less words coming out. Comprehension may be preserved, but the output becomes lost. And really, this, in fact, is, instead of the frontal lobes being destroyed, this is more the left hemisphere. Maybe the left frontal, that's being shown here on this PET scan, is the left frontal lobe is losing its ability to generate energy, so there's a dark area on the scan, and so that is where the words are supposed to be generated, and the individual gradually loses the ability to speak. So here's a video, let's run this.
A little bit about the speaking problem that you have.
Yeah, I have trouble speaking. It was about 2 years ago I had trouble first, but it is gradually becoming worse. Yeah, I have trouble going to church and keeping up with the minister now, and I don't talk to my wife, or I don't talk on the telephone at all.
Okay, so this is sort of the mild stages of this condition. And over the next 2 years, the speaking would get slower, less words, until it's just a broken word at a time. And so this is the progressive aphasia, primary progressive aphasia, or progressive non-fluent aphasia, subgrouped under frontotemporal dementia. So there's no personality change here. He's still calm, but it's the language for him. Okay, next up again, in the younger individuals, a progressive fluent aphasia. This is a type of aphasia, also left hemisphere, a little more posterior, where there is good output, but lack of comprehension and lack of word meaning. So someone's vocabulary is destroyed. Able to create words, but not the correct words. Again, left hemisphere, degeneration, often in a younger individual. Here's an example.
Could you please do what I say? Can you please touch your chin? Can you touch your chin?
What's the chin? Tell me what the chin is.
It's on your face. It's in the lower part of your face.
Where's on the face? What's the chin on your face? Is this or?
Yes.
Is this what's called the chin?
Yes, that's your chin.
Okay, I didn't have that. I just know the eyes and the ears and the nose and the the mouth and the tongue.
Good.
Oh, and the lips too, and the face. But I didn't know. And what do you call this? Is that a key thing?
The chin.
The chin. Is that a key thing?
It's quite dramatic, isn't it? And so what has happened? So his output is still fluent, and yet his comprehension of what I'm asking is decreased, and his word understanding is what is the chin. So that word, that very simple word that we learn as a child, has been erased. He sort of remembers, like he's pointing to it, but there's a little bit of left, but the meaning of that word has been taken away.
Could you please?
Let's see. Oh, yes. And also an aspect of this is reading is diminished, and the ability to do complex reading is diminished. So assuming he knew how to pronounce the words yacht and colonel, that higher level reading skills, the skills are also eroded.
Can you please read these words? Can you read that word for me?
What's that? Wychach? Wyach?
It's a kind of boat.
Oh. Well, it's like a boat? You know, I don't know what that's called. I just knew a boat and a big boat is called a ship.
Can you read that word for me?
Is that colonel? Colonel?
It's a kind of military rank.
I don't know about that.
It's higher than a captain and higher than a major.
Yeah, I haven't been on these at all.
Do you know what that rank is?
No.
So, you know, of course, if he never knew what a colonel was, but I have a sense he did know what a colonel was. And again, the reading is diminished. Okay, and lastly, we'll talk about when this condition affects the right hemisphere. We've talked about the frontal lobes with the personality type, the left hemisphere with the non-fluent and fluent aphasias, and now this, if the right hemisphere is affected, then you get psychiatric seeming presentations and impaired ability to recognize faces. Prosopagnosia means the inability to recognize faces. Again, it's a critical aspect of our brain function that we only appreciate once we've lost. And here you can sort of see on the PET scan less energy usage on the right side of the brain. Associated features of FTD, well, the onset is often earlier than the age of 65, and that's why we're talking about it today. So slight male predominance, family history of similar disorder may be present. There can be Parkinsonism, again, which adds even more difficulty on an already difficult situation. And there can even be motor neuron disease, making an already difficult situation even worse, where if there's simultaneous gait problems or weakness, progressive weakness. And so you see, so it's a little bit different than the 85-year-old who has short-term memory difficulties, because that is the more typical presentation of Alzheimer's disease dementia that we are more familiar with. Here are younger individuals with this significant personality or language problem. And you know, their short-term memory might be pretty good. If you're able to get through the barrier of the language problem and give them some word recall, they'll get them all. So the short-term is actually not bad. Short-term recall is okay. But the language is being decimated. Or their personality is changing. And they're younger. Again, another striking picture here, that at the front part of the brain, the gyri of the cerebral cortex are becoming so thin. This knife edge atrophy is called. And so again, the brain cells are literally being killed. So it's not that it's not anyone's fault. It's not their fault that he couldn't remember what a chin is. It's just that the brain cells that subtended the word chin are being killed. So they're not there anymore, or their connections to their neighbors, the synapses are being destroyed. When you look at it under the microscope, this was actually first done by Arnold Pick, a neuropathologist 100 years ago. So his name, Pick's disease, was an old term for FTD. Pick's disease, instead of Alzheimer's disease, is Pick's disease. But really today the term Pick's disease is used more for a pathological description of these large protein inclusions. This is the nucleus. And here's this gigantic protein inclusion in the neuron, which is really killing the neuron. See, this is what causes this condition, is these proteins build up in the brain cells, killing them. And in these PIC bodies, there are protein accumulation which destroys the brain cells. And in fact, this protein has since been identified as tau. Tau protein, also implicated in Alzheimer's, is heavily implicated in frontotemporal dementia. And so PIC bodies stain for the tau protein, meaning they are made of tau, abnormal tau. So the question is, if we could understand tau, is there any way we could cure FTD? See, that's the simple question. It's also a very difficult question because the answer is we haven't done that yet. But the point is, if we could figure out what's causing these diseases, do we have a chance of stopping them? So tau is a protein that stabilizes tubules in the neurons, allowing the subway system of the neuron to transmit neurotransmitters from the cell body out to the terminals and then send off the transmitters so that communication can occur between brain cells. That's how the brain works, communicating with the other brain cells. So you need the subway system within the brain cells to transmit or transport the transmitters. Now, if the tau and the tau protein stabilize these tunnels, the tau protein stabilizes these critical tunnels within the brain cells. Now, if the tau starts to be hyperphosphorylated, too many phosphate groups, then these tau proteins stick to each other, forming those globs, PIC bodies, which means they're not available to stabilize the tubules, which means the tubule subway system breaks down and the neuron can no longer talk to its neighbors. So that's tau, these PIC bodies are made of tau sticking to itself when it should be sticking to the tubule stabilizing. And so the question, which of course I've been focused on for my entire career, is, do these proteins, like the tau, does that cause the disease? Or is that tau like a secondary marker, like a downstream effect, not a cause? Because if it was just an effect, and if you tried to treat that, you wouldn't do anything. Because if you just treat the effects, then you're not going to get at the cause. Or is the tau actually the cause? And if you treated the tau, would you actually stop the disease? This central question has not yet been answered for any degenerative disease. Alzheimer's, which is also made of proteins, by the way. FTD, which is caused by protein, or we think by proteins. This question has not been answered at all in any degenerative disease yet. And we hope it will be, and we hope the answer is yes. If we can stop those proteins, we can stop the disease. But that has not yet played out. So the tau gene is on chromosome 17, and essentially what happens is, in the cell, there's supposed to be a balance between the 3 repeat taus, which have 3 black dots here, and the 4 repeat taus, which have 4 black dots within the protein. There's supposed to be a balance. Now, when you look at the families with FTD, see, this is young onset dementia running in families, and we're going to sort of veer off into the genetics now. It turns out that most of the mutations that cause FTD in families are right around this exon 10, which is the code for the 4th repeat, this purple area here, this purple area. So when we look at this, the message that we take from this, or we think we take from this, is that if the mutations affect the tau, and the mutations cause the disease, that sounds like the tau is the cause. You follow me on that? If the mutations of the tau affect the tau and cause the disease, then maybe the tau is the cause. So genetic studies of these young onset familial cases have pushed us heavily in favor of the concept that the proteins are the cause. Because if you mutate the protein, you get the disease. The problem is we still haven't got the treatment, the one that stops the protein, that stops the disease. It hasn't happened yet. So the genetics are pushing us, yes, we're on the right track, but the studies of medicines that block proteins in these terrible conditions have not yet worked. So where are we at? We've got to keep trying. Now, I'm going to, for completeness sake, and I know you've got the slides here, you can review them later. It turns out that frontotemporal dementia is not always caused by tau buildup. A lot of it is, just like the PIC bodies I showed, but there's another protein called TDP43, which probably causes even more of the FTD out there. So if you're interested, you can certainly research and learn more about a protein called TDP43, which likely causes even more of the FTDs than tau does even. Probably 60-40, with 60% being TDP43. There's no tau in the brain at all, but full of TDP43. And the same question arises. Is the TDP43 the cause of the FTD, or is it an effect, a downstream effect? So some genes have been found, one called progranulin, that causes a lot of autosomal dominant familial FTD. The thing is, we don't know how progranulin leads to TDP43. We don't know that. But other genes have been found, and guess what? One of them is the TDP43 gene. So if you mutate that protein's gene, just like the tau example, you get the disease. Does that mean that TDP43 is the cause? We think it does. But again, we don't have the treatments to stop that yet. And here is one that's quite often talked about, called C9 open reading frame 72. It gets a lot of coverage, if you will, in the literature because it causes autosomal dominant, familial, genetic, early onset, young onset, frontotemporal dementia, and ALS in one. So the unfortunate individual develops both the FTD type that I showed. It can be any of the types, personality, language, any of them, as well as ALS, motor neuron disease, the weakness of muscles, fasciculations, which we know is equally, or if not more tragic, happening together. So if you see, we want to understand these genes so that we have a chance of finding a treatment for these terrible conditions, which, as you know, to this day, it's so difficult to treat. It's almost hopeless, am I right? You know of what I'm speaking. It feels almost hopeless. But is there any way we can find something to turn that around for the future generations? For completeness sake, I mentioned a term called logopenic progressive aphasia. Logopenia means decreased words. And it sounds like progressive aphasia, and it has symptoms between the non-fluent and fluent types that I showed. It's a difficult diagnosis because it's a fine distinction between these types. But if someone appears to be showing signs of both the non-fluent and the fluent together, and they're a little older, it could be, and there's atrophy on the left side. Again, that's a fine distinction from what I've already shown. But if they're a little older and they have mixed aphasia, we have a term called logopenia progressive aphasia that has often been shown to be the Alzheimer's pathology. Now, we've talked about neuropathology today, how we had the tau PIC bodies, maybe the TDP43 bodies. So here is our segue into Alzheimer's disease, which is another type of some young onset dementia, especially genetic. And how does the pathology of Alzheimer's differ from tau or TDP43? Well, here it is. You've probably heard that the Alzheimer's pathology is the combination of amyloid protein and tau protein. That is the pathology of Alzheimer's disease. It's a combination of both amyloid protein and tau. That's different than the Pick's disease I showed, where it's just tau. That's different than the TDP43 FTDs that I showed, where it's just TDP43 in the brain. Alzheimer's is the combination of both amyloid and tau together. That is the definition of Alzheimer's. And that's really where that word comes from, because Dr. Alzheimer, 100 years ago, was the first one to look at this under the microscope and see both the amyloid plaques and the tau tangles together, and that's the definition of Alzheimer's. Now, as you can imagine, the only way to look at the brain under the microscope is at autopsy. We don't really do biopsies. But at autopsy, after one has passed away, their brain can be sectioned and looked under the microscope, and you can look what proteins are there. Is it just tau? Is it TDP43? Or is it a combination of amyloid and tau, which is Alzheimer's? And that's how pathological diagnosis is made. All right, so we've talked about FTD and how it presents. Alzheimer's you're more familiar with. It often presents with this gradual development of short-term memory. And it usually takes place after the age of 65, but can sometimes take place before, which is why we're mentioning it today, and how there are genetic forms that can occur even younger. So gradual, again, over 2 years, a slow development of short-term memory difficulties, so someone may repeat themselves, not remembering they just said the same thing 5 minutes ago, asking the same question even though they just got the answer. I'm sure everyone in this room has seen that. And again, it can occur in younger people, especially if genetic. This is the neuropathology of Alzheimer's that has both the amyloid and the tau. The amyloid plaques outside the brain cells and the tau tangles. That's the same tau that I talked about in FTD. So there could be some link here, but in FTD with the tau, there's only the tau, no amyloid, none. So we think of them as separate diseases, and yes, they have different symptoms, we've talked about that, different ages of presentation, but there is some similarity in that the tau I'm talking about here is the same tau in that FTD. So as you may have heard, that in Alzheimer's, which is the largest form of dementia in the world, what causes it? Well, what causes these proteins? It's the same question. Are the proteins the cause, or are they just an effect? The central question of neurodegeneration. So factors like genetic risk, environment, inflammation, oxidative stress, we believe leads to too much amyloid first, then to tau, then to the brain cell damage and death, and to the dementia. And again, the biggest question here, and this is what's coming up in the research into new medications, is this amyloid part. Look, in the FTDs, you can get dementia with just the tau. So does this amyloid actually make a difference? And for decades, we believed that yes, the amyloid is the first step. And so all of the treatment trials that we've been part of at Bruyère and around the world have been removing amyloid. And the results of all of them have been negative. Now you might have thought, well, that's obvious. Look, you can clearly get dementia due to tau alone. Why are you attacking the amyloid? And sadly, you're right. It has failed. The reason that all the trials have focused on amyloid is that the medicines to remove amyloid have been much easier to develop. The amyloid is present outside of the brain cells, between the brain cells. So it's been easier to get a medicine into the brain and attack the amyloid. Developing a medicine to attack tau has been much more difficult. These tau tangles are inside the brain cells. So not only do you have to get into the brain through the blood-brain barrier, but you have to get into the brain cells through the membrane, the cell membrane. So that's been why the tau medications have been at least a decade behind development of the amyloid medicines. So over the last decade, we have tested multiple anti-amyloid medications in Alzheimer's of all ages, and they have all failed. And that has been extremely difficult on all of our patients and our research participants and even our staff, as we on the front lines are testing these medicines to no avail, to absolutely no avail. I'm happy to report that there are anti-tau trials which have just begun. We're part of them here in Ottawa, and we are looking forward to the next anti-tau trial and the next anti-tau trial, and I hope that the next decade will be filled with anti-tau treatments and other treatment approaches so that we can one day, I hope, tackle Alzheimer's and FTD, as the need is only getting greater, as you can imagine, with the aging population. So the anti-tau trials are underway, thankfully. Now, this is interesting. You think amyloid is meaningless, but this is quite profound. Here's how amyloid is made at the cell membranes of all the brain cells. And it's believed, and it has been believed, that the amyloid builds up and hurts the brain cells, induces the tau, and then forms the plaques to almost sequester them away, that the plaques are almost a dump site to get rid of them, and that they cause their damage early on in their smaller form. And this is the point I wanted to make, and this is also why we've thought that amyloid was so central. is that in the early onset, young onset cases of Alzheimer's, and again, after these individuals pass away, their brains are checked and they have tons of amyloid and tons of tau. And when families have been identified with multiple people in the family having this young onset form, so multiple family members developing Alzheimer's short-term memory loss in their 50s or younger, their mutations have all been in the amyloid protein and the processing of amyloid proteins. This goes back to that central question of degeneration. Is the protein the cause, or is it something else? And the strongest evidence of the amyloid hypothesis has been right here in the young onset genetic cases, because sure enough, all of the mutations in these families have been around amyloid creation. And in that these mutations cause extreme amyloid accumulation. And again, does that seem to push us towards thinking that amyloid is a problem? It really does. The mutations make more amyloid in a big way, and the people get dementia. So for 30 years, evidence like this has said, yes, amyloid is a problem. Because if you mutate it and make too much of it, people get Alzheimer's and they get it young. So people, the amyloid has to be a problem. We have to develop medicines against it. And we have, but yet they have not worked. So what does this mean? It means, obviously, we need to keep trying with new trials, maybe not for amyloid, definitely for tau and other treatment approaches. And again, this is just to underscore that all the mutations that I just described work on this pathway of creating amyloid and build up the amount of this fragment to massive levels. And they get dementia. You'd think that would mean amyloid is doing it, but my goodness, the treatment trials have told us otherwise. So what treatments do we have today? And we'll sort of end on this. I'm, again, sad to say the treatment options for all dementias and the young as well is so limited. This is, again, for completeness sake in your handouts. It's the cholinesterase inhibitors. Here's your treatment algorithm. Maybe you've been using them. I'm sure you have been using them or monitoring them already. We have 3 pill forms and 1 patch form. The pill forms tend to cause stomach upset, maybe muscle cramping and vivid dreaming, whereas the patch form, that Exelon patch, which is a once-a-day sticker you put on your shoulder, does not tend to cause as much stomach upset, much more, skin irritation. Skin irritation, as some people sort of react to the adhesive. And these medicines, these cholinesterase inhibitors, they don't act on proteins, amyloid, tau, they do not. They act simply on the neurotransmitter acetylcholine to try to increase the transmission of that transmitter, to increase brain cell activity, to try to increase cognition. Unfortunately, the underlying disease, which we think are these proteins, keeps on building up. So in the end, these conditions are not cures at all. They are of modest benefit only. They are symptomatic benefit only. They help a little bit, but not a lot. We try them, but the disease continues to worsen. We have memantine. We can add it to the cholinesterase inhibitor at a more moderate stage. Here's the dosing algorithm. Side effects are pretty rare. There may be agitation in some, headaches in some. And again, we can use both the cholinesterase inhibitor type and the memantine together, especially at the moderate stage, in hopes of slowing down or ameliorating symptoms, but the underlying condition continues to worsen. There's lesser evidence for SSRIs and SNRIs, essentially mostly in the depression or anxiety aspects of dementia. Trazodone can be used in mild agitation or sleep initiation, and in more severe agitation, atypical antipsychotics, let's say aggression, Atypical antipsychotics may be helpful to prevent injury to an individual or their loved one or a caregiver. And yet there is risk of these medications, increased risk of vascular events and death has been reported in atypical antipsychotics in dementia, and yet we use them because we want to avoid the worst manifestations of agitation and aggression. The treatments are limited, and we have no disease-modifying therapies yet for the reasons I've described. All right, to conclude. Early onset, which is really young onset. Early onset does not mean early symptoms. It means young age of onset, so under 65 or really under 60. Carries added difficulty given the early age of onset, which may mean likely active employment and safety issues, financial issues, and young families. Frontotemporal dementia, FTD, with its behavioral variants and the progressive aphasias, is the most common type of young onset dementia, which may be familial or may not be. There could be very much a sporadic case of FTD which presents at age 58. That's very possible, but there are familial cases as well, and Alzheimer's disease can also occur at a young age, but those are almost always some kind of genetic form. And actually, I did not mention this, and I will mention it right now. The genetic testing is very possible. And we have a wonderful medical genetics clinic here in Ottawa at CHEO, Dr. Boycott and others, who, with a referral of a young onset dementia, will test for all of the genes that I mentioned in today's talk. So for the FTD, you can check for the tau mutation. You can check for the TDP43 mutation. You can check progranulin and the C9orf. In Alzheimer's, you can check the APP gene, the PS1, PS2, those are the amyloid processing genes. Those can be checked with a simple blood test that they will order and do all of the counseling surround before testing and after results are received. And so do I refer many young onset dementias to the genetic clinic? Yes, I do. If the family is motivated to undertake the testing. I do some counseling around it, and then if they are motivated to undergo testing, I send many of my families with dementia in their 50s, with FTD or AD or any kind of dementia to the clinic, and they've done a wonderful job of arranging the testing and performing the counseling for me. Many times there is no mutation found, but sometimes mutations are found. And if a mutation is found in someone, that allows other family members to test themselves to see if they have the same mutation. Because if they do, they're at extremely high risk of getting a young onset dementia themselves. And if they don't have if they do get tested and they don't have a mutation, then they're at a baseline risk. So again, it's sort of a very emotional issue, getting tested. And if a mutation is found, it then empowers the rest of the family to get themselves tested if they want. And that in itself is a decision that family members have to make, but only if a mutation is found in the affected individual that we're seeing. Lastly, treatment options are still very limited. Despite a decade of anti-amyloid treatment trials for Alzheimer's of all ages, they have all been negative. Even in the last 3 months, there's been 2 major failures. Now, you may not have heard about that because failures don't make front page news. Successes will. If there was a new medicine for Alzheimer's that succeeded, that would make front page news, I guarantee you that. But the failures don't make front page news, but they do at our clinic, obviously, because we then have to inform all of the participants that the trial has failed and the trial ends. And even the last 3 months, 2 major international phase 2 and phase 3 studies have failed. Signaling difficulty for families, but also billions of dollars of lost capital from the companies trying to develop this. So they have no interest in failing. And yet the medicines have not yet worked. As I mentioned, the anti-tau trials have just begun. And I see them as part of sort of a new hope, if you will, of the next round of trials, which hopefully will deliver the much needed treatment for both the young onset, any age of onset forms of dementia. Thank you for your attention today.